Imagine you're helping a friend move, and they hand you this massively heavy, shifting cardboard box that's just totally packed with books.
Oh, the worst kind of box.
Right. But here's the catch. Instead of just holding it from the bottom with your bare hands, you have to carry it suspended between two, like, really stretchy, flimsy rubber resistance bands.
Okay, wow. That sounds terrible.
It is, because if you think about what happens mechanically to your body there, your hands and your forearms are going to have to grip those bands with this agonizing, unrelenting force.
Yeah, I mean, your muscles would be completely exhausted within minutes.
Exactly, because you're squeezing so hard your knuckles turn white, just trying to overcompensate for the fact that those bands offer absolutely zero stability.
Right, the muscles are doing double duty.
Yeah.
They're, trying to hold the weight, but also trying to create stability where none inherently exists.
And that brutal, exhausting scenario is actually the perfect entry point for the central question we are exploring today on this deep dive, which is, can tight muscles and loose tissue actually exist together in the human body?
And will not just exist together, but actively cause one another.
Right, because it sounds completely counterintuitive, you know? We usually think of a body as either generally tight or generally flexible.
We do. But the clinical reality, and we see this all the time, is that extreme looseness in one area practically guarantees extreme tightness in another.
Unraveling that paradox is our mission today. We're looking at how hypermobility, specifically a connective tissue disorder called Ehlers-Danlos syndrome, or EDS, triggers this massive systemic chain reaction.
A reaction that ultimately leads to severe pelvic floor dysfunction, yeah.
Exactly. And to do this, we're pulling from a really fascinating stack of sources. We've got specialized physical therapy guidelines, clinical studies, and these comprehensive medical center reports focusing on pelvic health.
And the data presents a really complex web of symptoms. I mean, patients are walking into clinics with issues that seem totally unrelated on the surface.
But when you look at the underlying mechanics, a very clear picture emerges. So if you're listening to this right now and you've ever dealt with unexplained pelvic pain, or you've been told to just do Kegels to fix a problem, you might want to pay close attention.
Yeah, because the guidelines suggest you might actually be making things worse.
Totally. So to understand how tight muscles and loose tissue coexist, let's introduce the two opposing players in this, like, biological tug of war. We have the connective tissue on one side and the pelvic floor on the other.
Let's start with the connective tissue, since the sources identify that as the root of the looseness.
Right. So the main culprit here is hypermobile Ehlers-Danlos syndrome, or HEDS. And at its biological core, this is a problem with faulty collagen.
Yeah, collagen is effectively the glue of the human body. I mean, it's the most abundant protein we have.
It's the scaffolding.
Exactly. It provides the tensile strength to our connective tissues. In a healthy body, those collagen fibers are braided tightly together, almost like a heavy-duty climbing rope.
But when it's faulty, like an HEDS, that rope is unspooled.
Right, the tissues are just overly flexible. You end up with joints that can easily subluxate, which means they partially dislocate, and ligaments that just do not hold your skeleton firmly in place.
And crucially for our topic, this faulty collagen isn't just in your elbows or your knees, it's the internal connective tissue too. The sources specifically highlight the endopelvic fascia.
Yes.
And for the listener, let's break that down. Fascia is basically the biological shrink wrap that encases our organs, right?
That is a great way to visualize it. The endopelvic fascia is this network inside the pelvis that's supposed to suspend and support your internal organs.
But in an HEDS patient, that shrink wrap is defective.
Right. It's more like a worn-out elastic waistband. It yields under pressure.
Okay, so our internal suspension cables are essentially bungee cords. That's the loose tissue. Let's look at the concrete foundation trying to hold everything up the pelvic floor.
The pelvic floor is a literal hammock of muscles at the base of your pelvis. We're talking about muscle groups like the levator ani.
And the levator ani functions like the main slings of this hammock, right? Wrapping around the urethra, the vagina, the rectum.
Exactly. And this muscular hammock has a massive nonstop job. It supports the weight of the bladder, the bowel, the uterus. It controls holding in urine and feces, and it's the anchor for your core stability.
So we have this really heavy load resting on a muscular hammock, but the ligaments and fascia suspending it from the top are made of stretchy, faulty collagen.
Yeah, it's a structural nightmare.
It reminds me of setting up a camping tent in a muddy field. If your stakes are loose in the mud and keep slipping, the only way to keep the tent from collapsing is to pull the canvas itself incredibly tight.
That's spot on. The body's natural scaffolding is too stretchy, so the muscles have to take over.
Yeah.
And the nervous system drives that entire process.
Because the brain is constantly monitoring the body for stability, right?
Right. It's running this background program, making sure your spine is supported. When someone has HEDS, their central nervous system detects that major joints, like the hips or the SI joint, are shifting around dangerously.
The brain realizes the physical structure is swaying and it just hits the panic button.
Exactly. It initiates a protective guarding response.
Mm-hmm.
It commands the surrounding muscles to tighten up to create artificial stability.
Because the ligaments aren't doing their job.
Right. The brain forces the pelvic floor muscles to become the primary stabilizers of the pelvis. This forces the levator ani into a state of chronic, unending guarding. They're clenched, bracing for impact 24 hours a day.
And the medical term for this is a hypertonic pelvic floor. Hyper meaning over, tonic meaning tone. Overactive tension.
Yes, and this directly answers our central question today. Tight muscles and loose tissue don't just happen to exist together by bad luck.
The looseness actually causes the tightness.
Precisely. The extreme looseness of the connective tissue fundamentally forces the extreme tightness of the muscles. The body is desperately trying to hold itself together.
But the fallout of this dual system failure creates a highly confusing clinical picture, doesn't it?
Oh, absolutely. Patients present with two completely opposite sets of symptoms at the exact same time. It's why it often takes years for them to get a proper diagnosis.
Let's walk through what that physical fallout actually looks like, starting with the symptoms caused by the loose tissue.
Well, because that endopelvic fascia, that shrink wrap, lacks structural integrity, patients frequently experience pelvic organ prolapse.
Where gravity basically wins.
Right. The bladder, the rectum, or the uterus literally begins to descend or bulge into the vaginal canal. It creates a very uncomfortable, dragging sensation of heaviness.
They might physically feel a bulge.
Exactly. It's the direct result of the connective tissue stretching beyond its limit.
Okay, so you have this profound looseness and falling sensation, but then right alongside that, you have symptoms driven by the tight muscles.
Because the pelvic floor is in a constant state of spasm, it can't relax to perform basic bodily functions.
I mean, muscle has to be able to lengthen to allow urine or stool to exit.
Right. Yeah. So when a hypertonic pelvic floor is clenched shut, patients suffer from difficulty completely emptying their bladder or bowels. They develop severe chronic pelvic pain from the cramping.
The sources also highlight dyspareunia.
Yes, severe pain during sexual intercourse, simply because the muscular entrance is rigidly guarded and cannot yield.
Now, the clinical studies also list incontinence, urinary, and fecal leaking as a primary symptom of a hypertonic pelvic floor. And I have to push back on the logic of that for a second.
Okay, lay it on me.
If I go to the gym and I hold a plank for a year straight, my core is going to be incredibly strong. If these pelvic floor muscles are clenching 247, shouldn't they have the grip strength of a vice? Why would someone leak if the muscles are stuck in the closed position?
It's such a good question. And it's actually the single most common logical fallacy surrounding pelvic health. It trips up patients and doctors all the time.
So what's the missing piece?
We have to draw a hard line between the concept of tone and the concept of strength. High tone simply means constant tension. It's a rubber band pulled taut and left there until it starts to fray.
So tension doesn't equal power.
Far from it. When a muscle is held in high tone for a prolonged period, it physically restricts its own blood supply. The muscle fibers squeeze their own capillaries shut.
Wow, so it cuts off the blood flow?
Yes. It creates a state called ischemia, a lack of oxygenated blood. And without fresh blood, metabolic waste products like lactic acid just build up inside the tissue.
It's essentially suffocating itself in its own waste.
Exactly. This causes profound fatigue. A muscle in a chronic spasm is actually an exhausted, deeply weak muscle. It has no energy reserves left.
So when you suddenly sneeze or cough?
Right. A sneeze requires a rapid, powerful contraction of the pelvic floor to close the urethra. But that exhausted, spasming muscle simply cannot respond in time. It gives out. It's rigid, but it's fundamentally weak.
The mechanical failure is fascinating. But the research points out that the dysfunction doesn't stop at muscles and ligaments, right? The nervous system gets dragged fully into the mix.
It does. The constant shifting and gripping eventually scrambles the body's communication lines with the brain. And this happens on three distinct levels, starting with direct nerve compression.
Because the pelvis is a major junction box for nerves.
Exactly. When hypermobile joints are constantly shifting and grinding, they inevitably stretch or compress the nerves running through there. like the pudendal nerve.
Which is the primary sensory and motor nerve down there, the main power cable of the pelvis.
Right. When the pudendal nerve gets stretched by loose joints or compressed by spasming muscles, it causes pelvic neuropathy. Patients experience severe shooting nerve pain or strange sensations like numbness and tingling.
The hardware of the nerve is literally being crushed.
Yes. But then we get into the software of the nervous system. The sources emphasize that many people with EDS also suffer from dysautonomia.
That's a dysfunction of the autonomic nervous system, right? The background operating system.
Exactly. It controls involuntary functions you never think about. Heart rate, blood pressure, digestion, and crucially, bladder and bowel control.
So the actual signals telling the bladder to hold or release are getting scrambled.
Yes. The autonomic signals become uncoordinated. The brain might say, empty the bladder, but the signal to relax the sphincter gets lost or delayed. The network is glitching.
And that leads to the third neurological issue, which honestly might be the most surprising part of the research. Impaired proprioception.
The brain's 3D map of the body.
Right. Your ability to sense exactly where your joints are in physical space without having to look at them.
In a healthy body, your joints and ligaments are packed with sensory receptors that constantly ping the brain with location data. But because the collagen in HEDS is faulty, that location data is wildly inaccurate.
The sources actually mention that parents of kids with hypermobile EDS often notice them having flailing arms and legs during sports.
Right, they appear clumsy because their brains literally aren't tracking their limbs accurately. Their internal GPS is fuzzy.
But how does a fuzzy internal GPS for your arms or legs end up severely damaging your pelvic floor?
It comes down to compensation. If your brain doesn't inherently know how to stabilize your posture, you unconsciously adopt terrible body mechanics just to keep from falling over.
Oh, like changing how you breathe.
Yes. The most damaging compensation is shallow chest breathing. Instead of deep, relaxed diaphragmatic breathing, they breathe high in the chest.
Because taking a deep belly breath requires relaxing the core, and they're terrified to relax because they feel unstable.
Exactly. So they start unconsciously gripping their outer abdominal muscles, sucking their stomach in just to stay upright. But mechanically, the abdominal cavity is like a closed balloon.
So if you constantly grip your abs and take shallow breaths, you're squeezing the middle of that balloon.
Yes, you create massive, continuous downward pressure inside your abdominal cavity. And pressure has to go somewhere.
It follows the path of least resistance, straight down onto the pelvic floor.
You're taking that exhausted, spasming hammock of muscles, and you're constantly pressing down on it with the force of your own intra-abdominal pressure. It accelerates the organ prolapse, magnifies the nerve pain, and makes the hypertonicity so much worse.
So we have a patient dealing with loose structural tissue, exhausted muscles, compressed nerves, a glitching autonomic system, and a postural habit that's crushing their pelvis.
A perfect storm.
Which brings us to what the clinical guidelines highlight as the treatment trap. Because the symptoms like incontinence and heaviness mimic general pelvic weakness, patients turn to the single most famous pelvic floor exercise in the world.
Kegels.
And for this specific condition, the clinical consensus is that doing Kegels is arguably the worst thing you can possibly do.
It is. But it's the standard cultural advice. Magazines, blogs, even general practitioners will tell you, if you leak when you sneeze, do Kegels. Squeeze and contract to build strength.
But applying Kegels to a hypertonic pelvic floor, I mean, it's like waking up in the middle of the night with a severe screaming Charlie horse cramp in your calf muscle and trying to cure it by jumping out of bed and doing heavy calf raises.
That is exactly what it's like. If you forcefully squeeze a muscle that's already locked in severe spasm, you're only going to generate more ischemia, more pain, and more tightness. You're adding fuel to the fire.
So if the universal advice of just do Kegels is off the table, what do the specialized physical therapy guidelines actually mandate?
The clinical protocol is absolute on this. Treatment must begin with profound muscle relaxation. You cannot strengthen a muscle until you have restored its normal resting length and alleviated the spasm.
But how does a physical therapist actually accomplish that? You can't just tell someone with joint instability to relax. Their brain is stuck in an unconscious guarding mode.
Right. You have to systematically dismantle the body's canic response. And proper physical therapy usually starts entirely outside the pelvis.
With the breathing.
Yes. Retraining the breathing. Therapists teach diaphragmatic belly breathing. It teaches the patient to stop chest breathing and stop gripping their abdominals. This immediately decreases that downward intra-abdominal pressure.
It takes the heavy box off the hammock.
Exactly. From there, specialized pelvic floor PTs use manual muscle release techniques. Like how a massage therapist releases a knot in your shoulder, they work externally and internally to physically coax those spasming levator antemuscles to let go.
But manual release isn't enough on its own, is it? Because of that impaired proprioception.
Right, the brain needs to relearn what relaxed actually feels like. And that is where biofeedback comes in.
Let's dig into that because it sounds like science fiction, but it's incredibly practical.
Biofeedback bridges that brain-body disconnect. The therapist uses external sensors or an internal ultrasound probe connected to a screen. The patient can visually see a graph of their muscle activity in real time.
So because their proprioception is faulty, a patient might genuinely feel like they are relaxing, but the screen shows the graph spiking high into the red zone.
Exactly. The muscle is still clenched tight, even though they think it's relaxed. So the patient has to search their mind for a different internal feeling, a different physical cue, until they see that line on the screen physically drop.
They're mapping the internal sensation to the visual feedback?
Yes. It trains the brain to recognize the difference between clenching and resting. It's a slow, methodical process of rebuilding that internal GPS.
And then, only after the muscles learn how to drop their tension and return to a normal resting length, can the actual strengthening begin.
But the strengthening focuses on the surrounding architecture. Progressive, functional strengthening of the core, the glutes, the hip stabilizers.
To build up the heavy outer musculature so they can take over stabilizing the hypermobile joints.
Which allows the pelvic floor to finally retire from its extra job as the body's primary joint stabilizer. You can go back to just being a hammock.
But looking at the mechanics of retraining the nervous system, releasing internal spasms, and rebuilding the surrounding muscles, we are looking at a very long road.
Treatment for this level of systemic dysfunction is entirely holistic, and it requires immense patience. It can take months, sometimes years, of practicing mindfulness, continuous posture correction, and tailored physical therapy to literally teach a hypermobile body how to stop unconsciously guarding itself.
You're not just doing exercises, you're fundamentally reprogramming the central nervous system.
Precisely.
Well, as we wrap up this deep dive, the dynamic between hypermobility and pelvic floor dysfunction really reveals just how deeply interconnected our anatomy is. You cannot look at a single symptom in isolation.
No, you can't. Stretchy connective tissue in a hip joint literally forces the internal pelvic muscles into a painful, hyperactive state of tension. It proves that tight muscles and loose tissue aren't a biological mistake.
They're intrinsically linked in a desperate chain reaction of compensation.
And, the relevance of this mechanic goes far beyond patients diagnosed with a genetic condition like EDS. Even if your collagen is perfectly healthy, chronic tension, poor desk posture, high emotional stress, they can easily trigger that same neurological guarding response.
Causing a hypertonic pelvic floor.
Right. The clinical data suggests this dysfunction is vastly undiagnosed, affecting as many as 1 in 10 people who are walking around right now with unexplained pelvic pain, lower back aches, or hip issues.
Which leaves us with a final thought to ponder long after we finish our discussion today. We've seen exactly how our physical muscles are capable of unconsciously gripping so hard that they cause severe systemic dysfunction, all just to keep our physical joints stable.
Yeah.
So it really makes you wonder, if you're experiencing unexplained physical pain or chronic fatigue, how much of that is actually your body secretly trying to hold you together, emotionally and physically, in response to the invisible stress in your life? Just like gripping those resistance bands tighter and tighter, working absolute overtime just to keep you standing.